record. All right. So we are going to continue along with the Thera E2 material. Specifically, we are going to start with the get rid of that. Start with drug interactions. Now, when we talk about drug interactions, it's very, very, very important to put these things in context of how applicable they are. For instance, when we have drug-drug interactions that, put someone at risk of seizure, does that necessarily mean that we're going to cause seizures in someone who's never had one before? Maybe, maybe not. All we know is that there's an increased risk. With drug interactions, there's no hard and fast rules about what can happen. Same thing with side effects. All we have is percentages of people who get certain side effects. And so with drug interactions, we just have to be mindful of when we are stacking certain effects. When we look at the different kinds of interactions, obviously we have our drug-drug, which is the bread and butter of pharmacy. This is why doctors call us all the time. We also have drug food, which is more about counseling points for the patient rather than something you're going to be talking to a provider about. Maybe a nutritionist, maybe stuff like that. I don't think she really does the other three, which is drug, herbal, drug nutrient, and drug disease, right? She just mentions them. Oh, it's bot. Okay. Did he go in depth about yeah, he didn't do it for us either. Mostly because there's not a ton of them to talk about at this point in the pharmacogenomic things. Yeah. All right. So let's go through and let's talk about these. For our first point about drug-drug interactions, the important point here is really talking about the additive effect of drugs. Sometimes drugs have a that when we add them together, what can end up happening is a combination can cause a new adverse drug reaction or make a known one worse. When we talk about drug interactions, really what we care about more is this idea of clinical relevancy, which as you guys do more and more work, you are going to discover what is clinically relevant and what is not clinically relevant. All it comes down to is a combination of what is the combination going to cause plus what is the patient at risk for. So the drug interaction equation is what is the drug combo plus risk factors for the patient already. Now, when we talk about risk factors, there's a couple of key points, which I will change this color so we can coordinate. There's a couple of key points that we have to be aware of. The first is the age of the patient. Part of it is that older people tend to have more things that are wrong with them, and so they tend to get more drugs. But there's also there's polypharmacy, but there's also pharmacokinetic changes in that person. And can anyone name what some of those potential pharmacokinetic changes might be? What kind of things change in old people in terms of how they metabolize or get rid of drugs, how they distribute? Yeah, renal function, liver function, body mass. These are all huge, huge points about as we get older. One of the biggest factors for old people is specifically their renal function and their liver function. This is something we constantly monitor with people in the hospital because, as you guys saw with AKI, things can get really bad very quickly. The other risk factor that we really care about is their past medical history. We can divide this into ideas of acute versus chronic. And the way to think about this is an acute disorder is going to cause more changes and more interactions than a chronic disorder. An acute disorder is going to cause more problems than a chronic disorder. The reason for this is because acute disorders are generally very bad and they hit hard. So think about AKI. Suddenly your kidney shuts down. Now you're not processing any of the drugs. Or you're severely dehydrated. Well, now you're concentrating the drugs in your blood. So when you compare the acute effects of a drug interaction or acute disease on drug interactions versus chronic, we worry more about the acute issue. The last part here is also their social history. So we care about things like smoking, which includes both nicotine and marijuana. Marijuana is a pretty potent drug. The cannabis has several compounds that are pretty potently interacting. We also care about alcohol, especially when we talk about CNS depressants. Any psych med is going to interact with alcohol. And the last social history that I want you to be aware of is socioeconomic status. Socioeconomic status. So someone who has maybe not as good of insurance, or they're homeless, or they're about to lose their job, that is going to affect what drugs they're able to get, right? So money is a huge factor in the outcome of patients. When we talk about the drug combination itself, there's two broad categories that we care about. The first is the pharmacokinetic cause, PK, and the second is the pharmacodynamic cause. Some combination of drugs will cause both. Most will just cause one or the other. When we think about PK, I want you to think ADME. So this is all about the body acting on the drug. The body is absorbing it. The body is distributing it. The body is metabolizing it. Whereas when we talk about pharmacodynamic, we're talking about the effect of the drug, which the effects that we don't want turn out to be side effects. When we look at pharmacodynamics a little bit closer, we had already talked about how drug interactions, the three kinds of drug interactions, right? We have additive, synergistic, and potentiate. Now, there's also another one here that we can talk about in terms of drug interactions specifically, which is antagonism, which is the idea that 1 + 1 = 0, that adding two drugs will cancel each other out. Also, I am like, my mouse is dying at the same time my headphones are dying, which is not helpful. When we look at different drugs, did they give you specific examples for PK and PD that they want you to know? Or not really? I'm going to say probably not. Just because there's mountains and mountains of potential drug interactions. Let's go through each one of these with an example. I think that will be the best thing that we can do. More heavy on PK than PD. Oh, all right. Then in that case, do you want examples for PD or maybe not? Maybe not. Okay. All right. Let me put these back. Additive, synergistic, potentiate, antagonist. All right. When we talk about, oh, all right. Okay, cool. When we talk about pharmacokinetic, this is very, very, very specific about where the drug is in the body. Because of that, we care a lot about things like administration times or the hydration status of the patient. So let's go through ADME and we'll take a look. For absorption, absorption is all about where the two drugs are. So when you think about potential absorption drug interactions, what I want you to think about is problems, specifically usually in the GI tract. Can you have problems of absorption in other places, like a transdermal system? 100%. We do see those issues. But really, the majority of drugs are given by orally, so this is where we see the biggest issue. There are, the first example that they give you is the idea of pH. pH is really, really important because what you guys learned in med chem is that acidic drugs are neutral in acid, and basic drugs are positive in acids. So if we're talking about absorption, for an acidic drug, would we want it to be neutral or positive? Neutral. Only uncharged substances get absorbed into the body, which means that for acidic drugs, we want to keep the stomach very, very, very acidic. For basic drugs, if we make the stomach too acidic, then we end up charging it, and now it can't enter into the body. So we have lots and lots of potential drug interactions here. Luckily, the majority of drugs are acidic in nature. And so we can talk about a collection of drugs that require acidic conditions. First of all, what is the body's main way? How do we make the stomach more acidic? So if I said to you, go and make your stomach acidic, what would you do? Food. Food makes the stomach acidic. Why? Because when the stomach stretches, that causes the goblet cells, the primary cells, to release hydrochloric acid. So the drugs that she gives you, dabigatran, ketoconazole, and rilpivirine, for these drugs, do we want to take them with or without food? Do we want to take these drugs with or without food? With, without, maybe. All three of these drugs require acidic conditions, which means that they are better absorbed with food. They also have the added benefit of protecting you against like nausea, stuff like that. What would this also mean in terms of what kind of drugs we want to avoid? What would be a bad combination for these drugs? PPIs, H2 antagonists, antacids like Tums, Maalox, stuff like that. All these guys are going to make the stomach more basic, which is going to make these drugs harder to absorb. Now, let's say that someone has to take their dabigatran or else they're going to have a stroke, but someone also has a peptic ulcer. And so they need to take omeprazole in order to cure their peptic ulcer. What should we do? What should we tell the patient? How should they take their dabigatran and their omeprazole? Hours apart. How many hours? At least 2. So separate the drugs by at least 2 hours. Any questions about this? Maybe a question? No? Okay. Your EP? All right. Next on our list is all about complexation. There are two different kinds of complexation, but the one that we normally care about is chelation, which is when a metal binds to a drug. This is essentially just like having a ionic reaction, but the difference here is that the drug binds and doesn't let go. All of these drugs require separation from certain metals. So, for example, he gives the group the fluoroquinolones. For the fluoroquinolones, we want to avoid calcium. Same thing with the tetracyclines. We want to avoid calcium. I believe they also complex with magnesium and iron as well. What's a really, really common hypothyroidism drug? It's the number one most common drug in the world. Levothyroxine. Why do we have to take levothyroxine on an empty stomach? It chelates with everything. It chelates with all your main metals as well as most foods. It chelates with proteins, which isn't chelation, it's absorption, but it just it gets a bitch slapped. What is the minimum time that we need to separate these drugs? 2 hours. 2 hours is the golden rule. Oh, I think it uh why did I put this? What did I say here? Where the two drugs? Oh, absorption is dependent on where the two drugs are. That's what that is. Right, where the two drugs are in the body. Um I don't know what the fuck I was talking about. What is a drug that we use during hyperkalemia that would chelate a bunch of different stuff? You guys learned about it in the treatment of hyperkalemia. Not calcium gluconate, but a very, very good guess. Dextrose, maybe. I'll give you a hint. It helps with preventing potassium absorption. Do we remember K-exolate, for example? So K-exolate is a resin, right? It binds potassium. It's also going to bind lots of drugs. So any drug that is a intestinal binder, like the drug K-exolate that you guys learned on the last exam, is an example here. Most drugs. And the reason is because its purpose is to cling on to things. Next up, we have to talk about P-glycoprotein, which is the main way that the fluoroquinolone and tetracycline P-glycoprotein has a ton of different functions in the body, but specifically in the stomach, the purpose of P-glycoprotein is an efflux pump. So what this is going to do is it's going to take absorbed drugs and unabsorb them. Why would the body decide it wants to do this? Why would the body say, oh, I don't want this, get rid of it? Exactly. It's either absorbed enough of it that it doesn't need anymore, or it's tripped one of the sensors that says this is toxic, get rid of it. There are several drugs that are P-glycoprotein dependent. And when we talk about P-glycoprotein dependency, what we are talking about is absorbing the correct dose. So, for instance, if you inhibit P-glycoprotein, then you are going to have reduced efflux, which means more absorption. Would that mean that your bioavailability goes up or down? Would your bioavailability go up or down? Up, right? If you're absorbing more drug, that means more drug is entering the body, and so more is available, right? So does that mean that technically has your dose increased or decreased if you inhibit P-glycoprotein? Increased. And we call this the effective dose. So it's not the actual dose that we give, right? So for certain drugs like cyclosporin, we give cyclosporin knowing that P-glycoprotein is going to throw away 40% of it. But if we inhibit P-glycoprotein, then the effective dose is much, much higher, which can be pretty dangerous. Likewise, if you induce P-glycoprotein, you are going to increase efflux, which means we're going to decrease absorption. And so your effective dose goes down. So we have a few different drugs that are substrates of P-glycoprotein. These are things like cyclosporin, diltiazem, which is probably one of the most common calcium channel blockers out there. You guys have probably seen the drug losartan hanging around. That's a big one. And does anybody know what is special about digoxin and why we want to be careful about digoxin? So one of the things you will learn about dig is dig has a very small therapeutic index, right? So any changes to the pharmacokinetics of digoxin can potentially be fatal. Looks like he gave you just one inhibitor to bear in mind, which in this case is a food, grapefruit. The other one that I'm just going to give you guys, which this goes hand in hand, is Seville oranges, which is the popular orange in things like jams, commercially produced jams, orange flavored like preserves, stuff like that. They usually use Seville oranges. So people are like, oh, I don't even like grapefruit. Fine. And then they go and they eat their orange jam every day. And then they, die. Um, different stuff like that. One inducer I'm just going to give you guys. Again, this isn't the one that they gave you is this one. Um, but just because it's everywhere is aspirin. And the other inducer is cyclosporin. Cyclosporin induces its own absorption. So over time, it gets better and better and better at absorbing itself. Last up, we have GI motility. What we are talking about here is the place of absorption along the intestinal tract. Not all drugs are absorbed in the same place, right? So the faster that the bowels are emptying, the lower the absorption. What disease state causes faster emptying? Diarrhea. Exactly. So if you have a patient with chronic diarrhea, they may require higher doses. What are some drugs that could change GI motility that you guys have learned? Such as on the last exam for PICL or for MedChem. Right. The muscarinic agonists and antagonists. I'm not sure if I set it up here. For chelation, how much do we want to separate these drugs? 2 hours, exactly. One really, really big point that I want to make, and I've had to make this several times to my interns, we always worry about calcium because it's everywhere. Obviously, we know dairy is a huge source of calcium, but nowadays Does anybody else know where the major source of calcium comes from? Especially if someone doesn't drink milk in the morning, this can still be an issue. Eating bones for breakfast. Juice. Most juices nowadays, things like orange juice, uh have they're fortified with calcium. So just you have to let them know, hey, if you're gonna have juice, you just have to make sure it doesn't have extra calcium in it, especially orange juice. The reason for that is because if little kids don't like milk and they want to drink juice instead, they're still getting all their calcium that they need. Someone out there is like, fuck, I drink my levothyroxine with juice. All right, distribution. And then at the end of today, I'll tell you guys all about my weird patient I had today. When we talk about distribution, the main thing that we worry about is albumin. For your first Thera exam, did you guys have to memorize the albumin ranges? What I will tell you is that having the albumin range memorized in the back of your head is going to be the best benefit that you can give to you guys. 3.5 to 5. The reason why I mention this is because albumin is directly related to the protein content of the body. So someone who is very thin or is wasting, for example, so someone with cancer or is starving, something like that, they are going to have much less protein. What ends up happening is that for albumin, for highly protein bound drugs, so these are things like warfarin, phenytoin, valproic acid, I think. Um, uh, Many psych drugs. Um, Tons and tons of chemotherapy, lots of NSAIDs, lots and lots and lots of different stuff. If you have a reduction in the amount of albumin, this leads to more free drug. More free drug means more reacting drug. So the ratio between, oh, he focused on mostly absorption and metabolism. Okay. The ratio between inactive and active drug is highly pushed to active drug. And now you have drugs basically floating around the body where at levels they shouldn't be, which could be really, really dangerous for some of these drugs, especially phenytoin, warfarin as well. For metabolism, we have learned all about the different kinds of reactions, phase 1, phase 2. But really, where we care about mostly with drug interactions has to do with the CYP system. There are two big factors for changing the CYP system. The first is inhibition, which is way more common, and the second is induction. Inhibition put it in a different color. Inhibition is very quick and both in terms of onset and offset, which means that within hours we can start to see drug interactions. On the flip side, induction requires that the body make more enzymes. And essentially what that means is that this is going to be a very slow onset and a slow offset, which is why we have to be much more careful about induction than inhibition. Generally, we should be careful about both, but induction can be harder to repair because it takes much more time to have to get rid of. I have a chart for you guys, which you may have. Because you guys have been oh so good. I will post this on the Google Drive. Please use it every day. It will make your life so much easier. But it is a very comprehensive list of drug interactions. Different stuff like this, tons and tons of information, but you can see where we're basing things based on side effect or toxicity, or based on enzyme. What I will tell you is that you should be able to, as a pharmacist, you should know all the ones in bold off the top of your head. These are your major interactions. These are very common drugs. These are very common drug interactions. So knowing where these drugs are and how they work is going to be a major part of your role as a pharmacist. That being said, let's talk about what this does. When we have an inhibitor, we are talking about a specific enzyme. For example, inhibitor of 3A4. This means that we are going to decrease the metabolism of 3A4 substrates, which will result in increased levels of these 3A4 substrates. When we generally, what the effect of this is, inhibition, is that we end up with toxicities due to, which is what DT is, due to high levels. So we see toxicities, very, very severe side effects. In terms of induction, when we talk about inducers, What we are worried about is how increased metabolism of the substrates is going to lead to decreased levels of the substrates. Now, obviously, you can swap out the kind of enzyme for anything. I'm just giving an example. What we generally see here is reduced benefit of the drug. So maybe you're taking a drug like warfarin to prevent stroke. Well, if you were to take warfarin and an inducer at the same time, that would mean that there's less warfarin hanging around, which would increase your likelihood of stroke. So when you think about induction, think about reduced benefit. And when you think about inhibition, think about toxicities. The vocab word that we usually talk about is supratherapeutic for increased levels, supra meaning above. And for reduced benefit, we talk about subtherapeutic. Just as a little side note, you were going to hear a ton about St. John's wort. And when I was in school and all through my rotations and all through working, I had never seen anybody on St. John's wort. And I felt like they shouldn't be making such a big deal about St. John's wort. And then you go online and you realize that everyone is taking St. John's wort. Oh my God, they just can't get rid of it. They just love it, this shit. Um, so it it's just nuts. So please remember St. John's wort, even though you may not never see it in your pharmacy. Also, just want to show you that the P glycoprotein ones are down here, as well as OP. You'll talk about OP later. All right. Da, da, da. Is he going to make you memorize the different statins? No. The alternative switch to a different statin. It wouldn't really make sense for him to do that right then. Um, do, do, do. Yeah, it just seems like he's yeah. All right. That being said, when we talk about metabolism, the big thing that we should always bear in mind, especially nowadays where it's becoming more common for us to see it, is polymorphisms. When you think polymorphisms, which is mutations in the number of enzymes produced, I want you to think 2C9. 2C9 and to some extent 3A4. What's important to note is that a polymorphism is not about making, you don't make, do not make better or worse enzymes. Better or worse enzymes, you make more or less amounts of enzyme. So let's say that a normal person has the normal allele star one, 1 star, 1 star, is you have normally in every liver cell 50 2C9 enzymes. One of the combinations that we see is that if you are if you have the 2-star or 3-star allele, you are a poor metabolizer. What would that mean in terms of the levels? What would be a number that you would have for your levels? Decreased, something like 10. Much, much, much less. Or 25. As long as it's less. If you have retained at least one copy of the 1-star, or you're homozygous for the 2 stars, you are an intermediate. So something like 25 2C9 enzymes. Now, a couple of key points to remember about polymorphisms. Are polymorphed enzymes inducible? Can we induce or inhibit polymorphed enzymes? 100%. If you were a poor metabolizer, should we give you a 2C9 inducer or a 2C9 inhibitor? If you are a poor metabolizer, should we give you a 2C9 inhibitor or an inducer? Inducer, right. So let's look at this. Give an inhibitor or inducer for poor metabolizer. So right now, someone has decreased enzyme function, which means that we have increased levels of drugs. If we give a inducer, this will increase the function of the enzyme, which will decrease drug levels. Very nice. How would we describe someone with this genetic? What is the word that describes this kind of genetics? Homozygous. One of the ways that this might get described on the test is, oh, patient is homozygous for 3-star or star 3, whichever way it is. That's your clue that they're poor metabolizer. 3-star, 3-star. Versus if you hear, oh yeah, they're a heterozygous for 2-star. Well, heterozygous might mean that they're intermediate or they're poor, depending. Any questions about that? What's your question? Yeah. Homozygous refers to that we have the same allele on both chromosomes. So we have 3-star, 3-star. So if I describe someone as 3-star homozygous, then that means that they are most definitely a poor metabolizer. Versus if I say, oh yeah, that person is heterozygous for 2-star, at most they could be intermediate or poor. And so if the kind of question that you would be asked is like, select all that apply, what kind of metabolizer they are. Poor, intermediate, that sort of thing. Probably the other one that he gave you is like 17. I think I see. Yeah. So here we have ultra rapid. So here we're talking about having like 100 2C9 enzymes, which means we would want to give the opposite, right? We'd want to give an inhibitor to reduce that amount. Who is going to be a faster metabolizer? Someone homozygous for 17-star or someone heterozygous for 17-star? Homo. If you are homozygous for something, you are more that character. So if you're homozygous for 17, you are ultra rapid. If you're heterozygous, you're probably just regular rapid. What happens if you're 3-star, 17-star? Who knows? You're probably normal, right? Somewhere around there. You're 3-star, 17-star. Means your parents wanted to fuck up your liver. So it looks like he gave you a whole bunch of different drug tables. Is he expecting you to memorize the drug tables? Okay. I would honestly bolded, underlined, or starred. I would honestly I would just focus on this table, honestly. This is going to be your clinically relevant ones if he's going to talk about it. So if you're like, there's no way that I'm going to be able to memorize all these tables, just memorize this table. The bolded ones, not the entire thing. I mean, just look at 3A4 alone. It'd be nuts. So just that's what I would say. This is a summary of also all those tables just in one spot. I'll post it on Google Classroom once we're done here. All right. Drug food. And then we'll go on to the next packet. When we talk about drug food interactions, we're talking about consistency. For example, one of the drug food interactions that he gave you was between warfarin and vitamin K. Warfarin is an inhibitor of vitamin K dependent clotting factors. So in other words, it prevents the body from utilizing vitamin K, which means that the antidote to warfarin is vitamin K. So if we want to get rid of the effect of warfarin in the hospital, say someone is taking warfarin, which is used for clotting, then they, let's say that they accidentally took too much, then we would give them a shot of vitamin K to reverse it. But vitamin K is also very, very, very common in leafy green vegetables. Spinach, lettuce, broccoli, asparagus, cabbage, tons and tons and tons of stuff. What this means is that if someone eats vitamin K, it will block the effect of warfarin. That being said, let's say someone every day goes out and eats their salad. Every day at lunch, at the office, they have a salad. What should we tell that patient now that we started them on warfarin? Exactly. If you have a salad every day, keep eating a salad every day. If you don't eat a salad every day, don't start eating a salad every day. Don't start, often what will happen is people will get put on warfarin because they had a stroke. And so they're like, oh, I have to start eating healthy. And then they go out and they get a bunch of salad stuff, and then their INR gets all fucked up. So the most important thing for any drug food interaction is stay consistent. Same thing with grapefruit. If you drink grapefruit juice every day, your enzymes in your body are already changed to reflect that. You need to keep drinking grapefruit juice. If you want to stop drinking grapefruit juice, or you want to stop eating so much salad, you need to talk to your doctor about that, because we're going to need to change your drug levels. Speaking of grapefruit, just so that way we can bang it out, 3A4 substrates interact with grapefruit, as well as Seville oranges, just so you know. So the major 3A4 substrates that we care about are things like the statins, which only ALS are the ones we care about: atorvastatin, lovastatin, simvastatin, with atorvastatin and simvastatin being the most common. Warfarin is a substrate. And then tacrolimus and cyclosporin. Tacrolimus and cyclosporin. All of these are majorly affected by grapefruit. If we inhibit the metabolism of statins, what side effect are we going to see with statins? Simvastatin is not a good drug. It was only approved so that way, who is it? Who made, was that Genzyme? Vitaris or Viatris. Yeah, I don't like it. It has nasty. People are not adherent to it. But anyways, what is the major side effect that we should tell people on statins to look out for because they have too high of levels? It can cause AKI, kind of AKI. Specifically has to do with the muscles. Potassium, not a bad guess. Rhabdomyolysis. Muscle pain, back pain, calf, leg pain. All of these are indicative that your metabolism of statins has gone down and you have too high levels of statins. Same thing with warfarin. What would be the indication that your warfarin levels are too high? Right. Increased bleeding. Tacrolimus and cyclosporin we won't talk about because you'll get to that next year. All right. I'm going to talk about two things. Yeah. Caffeine. Caffeine is interesting because we care about it more in smaller people. Smaller people generally have a they're more affected by caffeine purely because it's more concentrated in them. Also, smaller people just tend to be like crazy caffeine drinkers for some reason. They're like little hummingbirds, just like wound up on crack all the time. But the big thing about caffeine is we care about two things: diuretics and stimulation. For diuretics, really what this does is that we increase urine production, which means that we're going to increase the excretion of anything in the body. So if something is highly kidney excreted, like some antibiotics or lithium, for example, then having lots of caffeine can affect the levels of them. So something that is 100% renally eliminated is going to be highly susceptible to this effect of caffeine. In terms of stimulation, really what this is all about is blood pressure, heart rate, and actually really that's it. Blood pressure and heart rate. Heart rate meaning like could lead to an arrhythmia, could be tachycardia. And by the way, this is the reason why it's bad in pregnancy. It's bad to have a woman with elevated blood pressure and a fast heartbeat. It's not good for the fetus. Puts too much pressure on the fetus. I think that's really it about caffeine. There's a lot to be said about nicotine, alcohol, and marijuana. But I won't go into that now. Any questions about this stuff? So I just went through and highlighted the most important stuff, but hopefully this kind of clarified some things. Any questions about this stuff?
Wait, so you say the statins increase
No, that So grapefruit is an inhibitor of 3A4. So if we decrease the metabolism of a statin, that would lead to rhabdomyolysis.
Gotcha.
Yeah, the memorization is going to be a bitch. Good luck. I don't think we had to do that much memorizing.
And decreasing the metabolism of warfarin increases the bleed.
Exactly. Yep.
Oh, and one more thing. What's TAC and CASA?
Tacrolimus and cyclosporin.
Thank you.
No problem. All right. Let's talk about gout. Which I think was at the end of the year for me. Gout is fairly straightforward. The reason for this is because really the goal is prevention, and if we have a flare up, then we try to get rid of it as much as possible. What we care about in terms of gout is what the presentation of the patient is at that time. So for gout is the buildup of uric acid crystals in the synovial spaces. So things like in the toes, in the joints of the toes, joints of the knees, everywhere where you do not want it. There we go. So we have gout is the uric acid buildup and crystallization in the joints. Is having uric acid in your joints a bad thing? Is having uric acid in your joints a bad thing? No, it is not. Right now, there is uric acid in your joints. The problem is the crystallization. When we make crystals, have you seen a picture of what the crystals look like? Did he show you a picture? If you look at the picture, here is what uric acid crystals look like. If you had to describe this as something, how would you describe it? Pointy, sharp, needle-like? This is what causes the pain. You have tiny needles in your joints. So the crystals are sharp. This is going to cause injury, which leads to inflammation. And it's this simple point here, sharp crystals, injury, inflammation, that is the backbone of what gout is. Does that make sense? Any questions about that? I always like to show the picture of gout. Gout starts off in 4 stages. The first is you are asymptomatic, which, if you remember, uric acid is produced via the metabolism of purines. Which are your purines, by the way? This is something you should know. Which ones are the purines? It is adenine and guanine. So the way that I like to tell people is that you have adenine, which is a purine, and you have guanine, which is a purine. Not to be confused with cytosine, which is not, doesn't work nearly as well. So for this phase, what you have is increased levels of uric acid, which is UA, which in males means that you have a above 7 milligrams per deciliter, and in females we have above 6. What's important to note about uric acid levels is that it has to be chronically elevated. If you went out and you ate a bunch of steak right now, you would have elevated levels of uric acid because your body is metabolizing all that protein, all that DNA. That doesn't necessarily mean that you are going to develop gout. Only a fraction of people with elevated uric acid develop gout. Only about 1 in 5. So what this means is that if you find a patient with hyperuricemia, elevated levels of uric acid, should we treat them? Should we give them drugs? No, we should make lifestyle changes. So just because a level is out of whack doesn't necessarily mean that, oh my God, we have to treat it. There are 3 major risk factors for developing gout. The first is obesity. Why is obesity a risk factor for developing gout? It's a risk factor for everything. Yeah. But joint problems, yes. But the reason is because they eat more. That's what it is. The second is a drug interaction. And what would be the drug interaction here? What would we think is going to be causing changes in the uric acid here? Chelation stuff, mostly we're talking about diuretics, things that are going to be working on the kidney. That's going to be the big, big, big one. And then the last part here is blood pH changes. Uric acid is a acid, which means that it's neutral in acidic conditions. If you change the pH of the blood, especially rapidly enough, then you can end up with some pretty potent uric acid formation. So we're talking about like ketoacidosis for diabetics. Von Gerke syndrome, sleep apnea. Sleep apnea is a big one. Von Gerke, it's a enzyme defect disease. Last one here is alcohol consumption. The reason is because uric acid competes with alcohol for excretion. So if it's competing with the alcohol, then that means that you are preventing it from being excreted. So these are some major risk factors. Alcohol wins because there's way more of it at the time. All right. So you have high levels of uric acid for about 10 years. You don't change your diet, and now you have an acute gouty attack. This is where you're getting the crystallization and the depositing of crystals. The gouty arthritis the goal of treatment here is well, let's talk about triggers actually before we get into that. The triggers here are based on either increased uric acid production or decreased uric acid excretion. What would be one of the easiest ways for us to increase uric acid production? Eating meat or drinking alcohol. What time of year do most people say they get a gouty attack? Thanksgiving, Christmas. In terms of excretion, decreased excretion, usually this has to do with like dehydration. Maybe they were out in the sun, they went to the beach, and then they got really, really dehydrated. Surgery, maybe their kidneys aren't working so well, trauma, diuresis, that sort of thing. So their kidney function has gone down. What this is all going to accumulate in is a couple of very significant symptoms. The first is that you get a huge inflammatory response. We're talking pain. We're talking fever. We're talking everything that you hate. Mostly at night that these things occur. So for the entire day, you think you're good. You go to bed and you wake up and you have a gouty attack. And then you can't go back to bed. Wake up to medchem. What I want you to bear in mind is that this is mediated by the immune system. All right? Any kind of inflammatory response is mediated by the immune system. So because of that, we have to be mindful that this is a potential way that we can treat it. One of the things that they do in order to, positively identify the gout is they might, in very, very, well, let's talk about treatment. There's two kinds of treatment. The first is prevention, which really falls on the idea of lifestyle modifications. What are some of the lifestyle modifications that someone should make to decrease the likelihood of gouty attacks? Less meat, little to no alcohol, decrease corn syrup, high fructose corn syrup, actually. More water, yep, help flush things out, 100%. More water is just beneficial for everyone. In terms of the flare, so someone currently has gout, right? They have the crystals in their toes. At this point, would reducing meat help? Not really. At this point, meat is going to do nothing for them. So what we're going to do is we're going to try to get the stuff out of there and then also decrease pain. That's really what we care about. So the first thing that we're going to use is colchicine, a tiny little pill. And what this is going to do is it's going to decrease the inflammatory response. Meaning, what system is it specifically working on? The immune system, right? The purpose of gout here is it yeah. The way that this works is that we are decreasing the immune response. What this means is that we are not lowering uric acid levels. But we do make a significant benefit in terms of pain, which is essentially what is the biggest issue right now. So the benefit of colchicine is that you're fighting the pain. When should we start colchicine? As soon as possible. And exactly. We want to do a loading dose of 1.2 milligrams, then 0.6 milligrams 4 times a day until it's gone. Tophi is the technical name for the white the tophi is the swollen limb. Um so this is a tophi. It's the lump, which you can get tophi anywhere. It's really, really, really gross. It comes out kind of like pus as well. All right. Great. We decreased the immune response. What is that going to do in terms of adverse reactions? Well, the first thing that's going to end up happening is that we get decreased immune system. Which, what is the effect of having a decreased immune system? What is that going to make it seem like? Yeah, you're going to increase the chance of becoming sick, right? Colchicine is also kind of tough on the stomach, lots of nausea, vomiting, diarrhea. And the big thing that ends up happening to people is myopathy. So they have muscle pain. Not muscle like, oh, the muscle surrounding their joints. It's like their legs or their back. So they're kind of trading one issue for another. One of the big contraindications for using colchicine, and you have to remember this, is renal failure. Colchicine requires you to have a good liver, not liver, have a good kidney. If you don't have a good kidney, it's not a good option. This brings us to the point that if you cannot use colchicine because you have a bad kidney, we want to use corticosteroids. Hydrocortisone, budesonide, NVD, nausea, vomiting, diarrhea. The trifecta. Corticosteroids, again, decreasing the inflammatory response. So all the same points as colchicine. All the same points, same mechanism of action, same, we want to start the same thing, start it as quick as possible. Similar adverse reactions. I will just say that we're going to decrease the immune system. Especially, really anyone of any age, you get mental status changes. Corticosteroids are psychotropic drugs. They can cause mania in people. People have murdered people on corticosteroids before. And the woman that did that was successfully acquitted because she said that, you know, it wasn't her fault. She was on steroids. Nausea, vomiting, diarrhea. When we talk about corticosteroids, their benefit is obviously we can't use it in renal failure or polyarthritis. So if you have a bunch of gouty flare-ups across the body, we'll just give you systemic corticosteroids. We're not going to give you colchicine. The corticosteroids will work much better and much more systemically. The last thing that could be used in terms of pain is NSAIDs. So again, all of these drugs are about reducing pain, reducing the inflammatory response. In NSAIDs, the mechanism of action is a little bit different, where we have we're decreasing pro-inflammatory signals. So things called interleukins, and the benefit of using these is that they can provide relief generally more consistently and faster than colchicine in some cases. The only one, or not the only one, the one that gets used all the time for gout is indomethacin. The reason is because indomethacin is a wild drug. It does the job very well. But my God, will it really fuck someone up? It is potent. It does the job. It's also really acidic in the stomach. Next up is naproxen, followed by sulindac. Um, the uh the big thing with NSAIDs in terms of their contraindication is renal failure as well. A lot of these drugs can't be used in renal failure. You also really have to taper the drugs. So you start at the dosing, yeah. So for indomethacin, so what's important to note about the dosing here is that you have 3 days of the full dose, then days 4 to 7 is a taper. Can use. We want to use corticosteroids in renal failure. That's where they fit in. So for indomethacin, we're going to start 50 milligrams TID, and then so for the first 3 days, and then for days 4 through 7, we're going to do 25 milligrams TID. Naproxen, 750 milligrams, then daily, then 250 milligrams TID. So full dose, 3 days, taper for the rest of the week. Other aspects of treatment is did she talk about interleukin inhibitors? No, it doesn't look like it. Yeah. So these are for our flare, right? Once we have the flare under control, meaning we have the pain under control, now we need to have our uricosuric drugs. Uricosuric drugs are the ones that are going to actually decrease the uric acid levels. So up until now, we've had no way to get the uric acid out of you when it happens. The Where these are going to get used is in chronic gout. What we care about here is that you consistently keep getting gout. These are not drugs that you would use in someone who gets their first gouty attack. Maybe that's their only gouty attack they're ever going to get. This is for someone who's consistently getting them, usually because of genetic issues or because of a drug combination that we can't get rid of. First line, allopurinol. Hands down, the drug that we're going to be using is allopurinol. The alternative is febuxostat, but it really does not do the job. Allopurinol is the usefulness comes in both overproduction and under excretion. So if someone is overproducing uric acid, we can use allopurinol. If someone is a under excreter, using allopurinol is also beneficial. Whoop, whoop. What these drugs are doing is, as you guys have pointed out, they're xanthine oxidase inhibitors, which means that they are preventing the production of uric acid. The why? So my question for you is, the xanthine is oxidized into uric acid. By inhibiting xanthine oxidase, we are going to lower uric acid levels and increase xanthine levels. Why is that beneficial? So obviously we're going to have less uric acid, but wouldn't it be just as terrible to have more xanthine? The reason is that xanthine is more water soluble. So unlike uric acid, which is likely to crystallize, xanthine does not, which is why we can use it so well. One of the big issues for allopurinol specifically is a hypersensitivity reaction. So a big contraindication for allopurinol, and you over the next 2 years, you guys are going to be quizzed on this all the time, is having the HLA B star 5801 allele. This increases the likelihood of I think life-threatening rash, right? I think it this is most common in people of Asian descent. I don't think it's Steven Johnson syndrome. Let me look. HLA-B 5801. It is Steven Johnson's, or the worst one, which is toxic epidermal necrolysis. It's I believe, if I'm not mistaken, it's Han Chinese. Not necessarily like Islander or Southeast Asian. So Han Chinese are at the highest risk. In terms of dosing, for allopurinol, we're going to do 100 QD going up to 300 to 600 QD. And then for febuxostat, it is 40 milligrams to 80 milligrams. The reason why we don't use febuxostat is it's actually better tolerated than allopurinol. The reason why we don't use it is because it's contraindicated in many cardiovascular diseases. So if someone has heart failure, if they're, they've had an MI, if they've had chronic hypertension, any of these atherosclerosis, any kind of cardiovascular disease, febuxostat increases the risk of death hugely. So the reason why we don't use febuxostat, even though it's usually better tolerated, is because lots of people have cardiovascular disease. It's just not worth the risk to use it. Moving right along. Oop, we're at 9 o'clock. We have 2 more drugs. Are people fine if we keep going? Or do we want to take a short break? It's not going to take me that long. Okay, I'm just going to keep going. If people need to sign off, then have a good night. But all right, we'll keep going. No problem. Take care. Second line is our the probenecid. Probenecid is used in under excretion of uric acid. So it is not helpful in someone who is an overproducer. The way that it works is that it prevents reabsorption of uric acid in the tubule. So in other words, you're increasing excretion of uric acid. It's specifically it's inhibiting what's called the URAT1 transporter. In case if you need that vocab word. In terms of contraindications. What is, oh, I can't get rid of it. In terms of contraindications, the first one that we care about, contraindication, or like ADR. We end up getting ureter stones. Specifically, you start crystallizing the uric acid instead of in your joints, it's now in the urethra. Not great, right? So now you have sharp little crystals poking your urethra, inside your bladder. So what should we tell people to do in order to prevent this? If they're taking, right, stay hydrated. They need to drink lots and lots and lots of water. They need to flush all of this out. This is a sulfa drug. So someone with sulfa allergy should not be taking this. And then in terms of contraindications, this drug is not useful in chronic kidney disease, CKD. So it should not be used in, right. If your kidneys is not operating very well, you don't want to use a drug that is going to fuck with it. The last drug that we need to talk about is, and if anyone needs me to go back, just let me know, is pegloticase. Yes. No, I realized that. I zoomed out of there really, really quick. No worries. The last one that we're going to look at is pegloticase, which, based on the name, what does that tell you about the function of this drug? What is it specifically? ACE. Like if I talked about a kinase drug, or if I talked about a esterase, yeah, not necessarily hydrolyze, it's just an enzyme. So pegloticase is recombinant uricase. And uricase is the enzyme that breaks down uric acid. So the mechanism of action of pegloticase is that it causes the breakdown of the uric acid crystal. Um, the whoops. For our drug here, the use of this drug is really if in treatment failure of first and second line drugs. What we mean by this is that you still have greater than 2 Gouty attacks per year. So you're on allopurinol, you're on linezolid, or you're on probenecid, and you're still getting Gouty attacks. Or maybe you can't take allopurinol because you have the HLA-B 5801 allele. Maybe you have heart failure, so you can't take febuxostat. So we would add pegloticase in this case. So it's only really used in cases where we can't use the first line, or the first line isn't working. In terms of side effects, Because this is a recombinant drug, meaning that it's produced in a foreign cell and then injected into your body, you can have what's called infusion reactions, which essentially means that you have an allergic reaction to it. And these can be pretty severe, all the way up to, pretty nasty anaphylaxis. It's pretty bad. And so we have to be really, really careful. We might give like a test dose, different stuff like that. Contraindications: concurrent use of a xanthine oxidase inhibitor or probenecid. You cannot use these drugs at the same time. Very dangerous. The reason is because you're going to drop the levels too far too quickly. The other part too is that it makes it hard to see if pegloticase is working, because we don't know if maybe the drugs just suddenly started working. So you have to stop the other drugs. The other big point about this is that the mechanism of action, what it does is it takes uric acid and through pegloticase, we end up with allantoin. Part of what comes out of this reaction is hydrogen peroxide. Hydrogen peroxide is a major oxidator in the body. So you cannot use this drug in someone with called G6PD deficiency, because they won't be able to deal with the hydrogen peroxide, especially in the blood, leading to hemolytic crisis. So their red blood cells start to explode and then they die. The other thing that can end up happening here is that you have significant damage to the heart, causing congestive heart failure. Not good. All right. Get out your cameras real quick. I have a picture for you, because I know you all love your goddamn pictures. There's your drugs right there. What a nice picture, right? No worries. I'll put this up online as well. So if you don't. But all right. This is where we will wrap up for tonight. Be on the lookout. I'm gonna post some patient cases probably tomorrow morning, and then we will have our tutoring at 7.